Thanks a lot, Morgan. Good night. Thank you so much for your invitation. I'm extremely glad to have the possibility to share with you our preliminary experience, mine and of our group, regarding the impact of contrast clearance analysis in the management of intrinsic brain tumors recurrences. So, to date, both radiation necrosis recurrences are main issue in neuro-oncology, and the capability to distinguish these two entities represent a diagnostic challenge. We can see in these slides how the treatment effects in the two main entities of intrinsic brain tumors, so glioblastomas and brain mets, is between a percentage between 5 and 30%, considering that both entities into the treatment effect that could be pseudoprogression, so an acute alteration within some months after treatment, and the real radiation necrosis that is a late effect between months and years, and it's clear that radiation necrosis, so the late effect, is the main late effect that can affect decision making in this kind of patients. So the increasing in these cases of volumes of contrast-enhancing lesions on MRI is able to mimic tumor progression. So which are the tools that to date we have to distinguish and identify these different entities? The first, spectroscopy, is an MRI-based technique that is able to analyze some characteristics we know very well of the tissue metabolism involved in the enhancing alteration, especially. Different PET technique, CT or MRI based, will employ different amino tracers or eventually of FDG with different results, not evidences to date. After the only, probably with some validation, that is the perfusion sequences of MRI with the capability according with the decrease or increase of the relative cerebral blood volume in the enhancing areas to distinguish between radiation necrosis and tumor, but with some limits, for example, the significant overlap, a low spatial resolution, and the susceptibility to artifacts. So, a promising tool that is the issue regarding which I'm talking to you about today, contrast clearance analysis, could be promising in the possibility to distinguish between radiation necrosis and tumor progression. What is the contrast clearance analysis? It's an MRI technique with, we will see after, two different MRI acquisition and able to reproduce, construct and fuse color maps that are called the treatment response assessment maps with the acronyms TRAMPS. What is so? We employ MRI technique, especially the T1 contrast enhancing MRI sequences with two different sequences acquired. The first 5 minutes after contrast injection is considered the early acquisition, and another after about 1 hour, 1 hour and a half after the contrast injection, that is considered delayed. We know generally that the contrast clearance could represent progression, while contrast accumulation regions can represent radiation necrosis. We will see how in detail now. This is a little bit the paradigm of this methodology. The first, we can see how there is an injection in vessels that typically show a rapid increase in the signal intensity followed by a relatively rapid clearance. So the subtraction, the image, the color that we can see in the MRI map is blue, is negative. The disease, so the tumor, the active tumor, with a dense vasculature also show a rapid increase in signal intensity, followed by a relatively rapid clearance, although the peak intensity is delayed in reason of the blood-brain barrier disruption, and the same way the subtraction is negative and so blue. Why, in case of contrast accumulation, areas with damaged vasculature typically show a slow accumulation of contrast with a positive red subtraction image. This is an example on the left, the early acquisition of MRI, in the center on the right, the delayed, and last on the right, the design of the contrast clearance analysis map with, we can highlight the blue areas with the contrast clearance and the red areas with the contrast accumulation. So we tried a little bit to understand the capability and the ability of the clearance analysis to differentiate radiation effect and tumor progression in a cohort of brain tumor patients already treated with surgery and radiation therapy. This is our numbers. So in about 1 year, 35 patients analyzed with these techniques, different histology, a group of primary brain tumors of 14 patients treated with surgery plus radiation therapy with or not concomitant and adjuvant temozolomide, 7 patients that underwent array radiation, so recurrent primary brain tumors, and after the group of brain mets, 21 patients with different histology, mainly represented by lung cancer, and treated with radiosurgery, both single fraction or hypofractionated radiosurgery. The paradigm a little bit of the MRI technique, so T1, the late and the delayed T1 with the contrast enhancing, diffusion imaging, and after the reconstruction of the contrast clearance accumulation or clearance pure in blue. This is an example in the superior part of a global segmentation of the lesion, including also by the FLAIR sequences the not enhancing areas after the reconstruction of the trans map, and on the right the reconstruction of, in this case, of the active disease, excluding and erasing all the other possible confounders, so highlighting the presence of active disease. In case of stable disease, the inferior one, we can see all the imaging segmentation in MRI, the design of the tram maps with the red into, so contrast accumulation, and the reconstruction on the right of the sequence with only the accumulation. So a rate of active disease lower in comparison with the case showed before. Some results from a statistical and also it's clear clinical point of view regarding this technique. The first is that there is a direct and statistically significant correlation between the results of the data of cerebral blood flow volume in diffusion MRI according with the contrast clearance, so the blue image compared to the contrast accumulation regions. Into the group of patients that showed disease, another very interesting data that we analyzed is that into this group in which the disease is present, we can reach some information also regarding the behavior of the disease at the time of the analysis. In fact, progressive disease showed a greater blue image, a greater blue results in comparison with a patient in partial response with the presence of disease or in case of stable disease with a lower intensity of the blue. Another interesting data is the fact that comparing the accuracy in detecting active disease and so progressive disease, TRAMS technique, so the maps by the contrast clearance analysis, show a more accuracy in comparison with diffusion MRI technique in detecting progressive disease. Some results regarding patients, 11 patients underwent surgical resection, 5 brain mets and 6 primary brain tumors, essentially glioblastomas. Regarding brain maps, both CCA maps and diffusion MRI techniques hypothesize this kind of result, 3 progression disease and 2 radiation necrosis. While the histopathology results was a little bit different regarding the brain mets in comparison with the 100% of correspondence in intrinsic brain tumors. At this point, we need to talk regarding these results in brain mets. So first is quite well established that when we encounter a recurrent brain met or a brain met that recurred after only radiation treatment, essentially there is a coexistence of both radiation necrosis and progression disease. So probably it could be a problem related to the sampling. In fact, histopathological data is pivotal and essential to validate this tool. In fact, we decided to perform another and further study only on 8 patients that underwent surgical resection in performing a correlation between radiation necrosis volume on histology and on TRAMS map, employing all the volumetric parameters that we described. But one time that we were able to reconstruct the TRAMS map, we had the patient into the operative room, we fused the image of the TRAMS map within the preoperative CT, preoperative MRI. We performed an intraoperative CT one time that we were at the level of the brain, and so trying to minimize the brain shift, starting to perform a consecutive sample collection in different points with different TRAM images, just to try to correlate different parts into the same lesion, giving to the pathologist every one of these sampling separated each one. In our series, 9 samples from 3 patients were collected, so 6 red rime or nodule and 3 blue rim or nodule. Here the results were better, with an amelioration in the capability to detect radiation necrosis, quite 85%, in comparison with a 65–66% in case of progressive disease. It's clear, very, very low number of patients, preliminary experience, but it could represent an idea for a future prospective study. So, which are the advantages of this technique? And high resolution and sensitivity, a clear differentiation between contrast accumulation and contrast clearance region, so it's a direct impact of the red on the blue and vice versa. The possibility to evaluate the entire brain tumor volume and the low sensitivity to susceptibility artifacts, while also some limits. The necessity of the delay scan, so a patient perform another T1 with a gadolinium MRI 1 hour after the first sequence, the inability to depict non-enhancing tumor regions, and the more sensitivity to motion artifacts. So, in conclusion, our preliminary experience showed a good correspondence between the data derived from the TRAM maps, both in detect tumor progression and treatment-induced tissues. With a superposable result in comparison with the perfusion MRI, but with an accuracy probably superior in the detection of progressive disease. This is sure that could improve patient management, coupled probably at this moment with other neuroradiological and metabolic technique. But I think it's the time to draw prospective study, both to employ this technique to decide whether the patient could be amenable for a new surgery, could amenable for bevacizumab, for example, for radiation necrosis, but also for the monitoring, in my idea, for the monitoring of immunotherapy in especially melanoma brain mets and so on. So our experience is an extremely good experience. And a great thank you to Brain Lab and to all my team, neurosurgeons, neuroradiology, and radiation oncologists. We work always together in this issue and in all neuro-oncology issues. Thank you.